procalcitonin is another marker which has proved to be very useful as a marker of sepsis and severe infection. Other markers include serum amyloid A, which actually predicts the chances of survival of patients with secondary amyloidosis and is not commonly used as a marker in the routine practice. Ferritin and its glycosylated form, another acute phase reactant, is used in certain specific situations like diagnosis of adult onset still disease or activity of still disease. And then there are markers of cartilage and bone turnover, which are complementary to other markers of inflammation. So if you just look at the relationship between pro-inflammatory cytokines and their effects on the body, IL-6 affects hepatocytes, causing release of acute phase reactants like CRP. On the bone marrow, it causes thrombocytosis, and through its effect on the CNS causes fever. IL-1 and TNF, through their action on CNS, cause fever, anorexia. Through their effects on synoviocytes, chondrocytes, increase matrix metalloproteinases, prostaglandins, etc. And through their effect on the bone marrow, cause leukocytosis and anemia. So this is the association between cytokines and the effects which occur because of their actions on different tissues. But the usefulness of serum levels of cytokines, cytokine inhibitors, or soluble cytokine receptors is still under investigation, and these are not currently recommended routinely as markers of inflammation or infection. If you compare the different biological markers which are available, ESR is cheap, easily available. High sensitivity CRP again has a low cost, is easily available, can be used. As opposed to that, procalcitonin is slightly more expensive, and there aren't many different assays available. And the same goes for cytokines, which are extremely expensive but not commonly available, and again their role has not been defined. Now, if you look at CRP levels in bacterial or bacterial infections, the levels are very high, and the same holds true for procalcitonin. So both are fairly good markers of bacterial infection, and the levels of both CRP and procalcitonin are low in viral infections. But CRP levels are high in serositis and in temporal arthritis. So basically here CRP levels will not allow differentiation between bacterial septic arthritis or serositis because of disease activity. So although CRP levels accurately mirror the clinical inflammatory status, they are high both in serositis and septic arthritis, so differentiation is not possible. But one situation where markedly elevated CRP levels are helpful is that of SLE, where it can allow you to differentiate between disease flare and presence of infection. CRP levels are not very high in SLE disease flare. I'm going to skip this. Okay. So what is the value of ESR in current practice? Should we ever order ESR in somebody who has a rheumatic disorder and presents with fever? A normal level has a negative prognostic value in association with normal CRP levels, and this is where the importance of ESR lies. Procalcitonin is turning out to be an important marker. It is produced very rapidly after an inflammatory stimulus. Basal secretion is through medullary thyroid cells and endocrine organs, but after an inflammatory or infectious challenge, procalcitonin levels are produced in many different types of cells, and levels reach very high very quickly. And procalcitonin levels have been shown to correlate with severity of infection and mortality. So this is turning out to be a very useful marker of sepsis and other sepsis-like conditions, and it is also useful in non-bacterial infections like severe malaria and systemic fungal infections. In ANCA-positive vasculitis, PCT levels above 1 nanogram per ml have been suggested to distinguish between infection and active disease, so fairly good marker. How about septic arthritis? Can PCT levels tell you whether the patient has septic arthritis or not? PCT is a poorly sensitive but specific marker of bacterial arthritis. Synovial PCT has also been checked in patients but is not found to be useful in discriminating infections from inflammatory etiology. And in emergency situations, one can use serum procalcitonin level and CRP to predict the chances of somebody having a bacterial infection along with the swollen joint because of rheumatic disorder. So procalcitonin levels measurement can help to distinguish between bacterial infection, other kinds of inflammatory processes, and systemic inflammatory response syndrome. In the case of a clinical flare, together with fever in patients with autoimmune diseases and vasculitides, a normal PCT level may imply that the cause is the disease itself rather than the bacterial infection. Infections which are associated with marked TNF release are the ones which are associated with highest procalcitonin levels, which means that the levels are going to be high in gram-negative infections, but false negative levels are also possible, and these are seen when the bacterial infection is localized and the systemic endotoxin load is low. So when do we see false positive procalcitonin levels? They are seen in adult onset Still's disease. That's one condition which I found during literature search. It has been found to be falsely positive in the absence of infection. Other markers like serum amyloid A are useful in specific situations, like viral infections, diagnosis of rejection of renal allograft, and in situations where corticosteroids are being used. As a workup of infection, one has to request imaging, and this choice would depend on the site or focus of disease, and MRI is becoming more and more important. Microscopy and culture are very, very important, and one has to send appropriate samples like synovial or other body fluids, sputum, urine, blood, etc., depending on the focus of infection. And this is also important because you need to find the etiologic agent, and that is important because you have to select your empiric treatment on those bases. So let's take a look at local antibiotic susceptibility data. This is a bit busy, but just focus on E. coli here. These are hospital isolates of E. coli, and these here are community isolates of E. coli. If you see here, 80% of E. coli isolates are resistant to third-generation cephalosporins. And from the community, up to 60% of E. coli strains are now resistant to third-generation cephalosporins. And the same holds true for fluoroquinolones. 74% are resistant to fluorinated quinolones. If you look at Staph aureus, around 37%, 36% from community, and 37% from hospital. These isolates are resistant to cloxacillin. So we have around 37%. So in somebody who is seriously ill with fever, the empiric choice of therapy for inpatients would be either piperacillin-tazobactam or a carbapenem with vancomycin. And in order to narrow it down, it is absolutely essential that you send appropriate culture so that the treatment can be focused and targeted to the causative agent. To summarize, autoimmune disorders and their treatment predispose to infection. Differentiation between disease flare and concomitant infection requires appropriate investigations and appropriate use of inflammatory markers. Procalcitonin serum levels have definite advantage over for diagnosis of sepsis and severe infections. And serial CRP may be useful because a decrease in CRP level tells you that your patient is responding to the treatment. Serum procalcitonin and CRP levels are useful in diagnosis of or supporting diagnosis of bacterial arthritis, and appropriate cultures should be performed. Empiric antibiotic therapy should be based on local susceptibility data. Thank you.